Good morning, everybody. First of all, I'd like to welcome you all to the 51 annual meeting of the Egyptian Society of Cardiology. On behalf of Professor Nabil Farag, the President of the Egyptian Society of Cardiology and the board, we would like to thank the organizing committee and the chairman of this meeting, Professor Amr Youssef, Professor Hussam Hassan, Professor Khalid Al-Maghrabi, for the excellent organization and the wonderful program for CardioEgypt. The first session in this meeting is a joint session between the EC HFA, Heart Failure Association of the European Society of Cardiology, and the Egyptian Society of Cardiology. It's a very interesting session for topics in heart failure. And we have the pleasure that we have the executive committee of the HFA in this session. Professor Giuseppe Rosano is the president of the Heart Failure Association of the EC, a professor of cardiology at St. George's University of London. And we have also Professor Marco Metra is the president-elect of the HFA, and Professor Peter Sivorovich is the past president of the HFA ECC. So without further ado, I'd like to welcome and introduce the first speaker, Professor Giuseppe Rosano. He's going to talk about guideline-directed medical therapy, sequential in-hospital initiation, guideline-directed medical therapy in heart failure. Professor Rosano, the floor is yours.
Thank you, Professor Abdelhamid. Thank you, Magdi. It's a great pleasure to be here. First of all, I wish to say that it's now Professor Metra who is the president of the HFA yesterday, and he will be a great president for the association for the future. So this is my declaration of interest, and as we know, the 2021 guidelines give a class 1A recommendation for the ACE inhibitors, beta blockers, MRA, and dapagliflozin and empagliflozin, and class 1B for sacubitril valsartan for replacement of ACE inhibitors. But the main change that has been introduced by Professor Metra on behalf of the group has been the change in the structure of the approach of patients with heart failure. So rather than going towards with the old stepwise approach, now there's a new approach that is based on the simultaneous initiation of the 4 foundation therapies, of the 4 pillars, in order to reduce mortality and morbidity. Once that is done, then patients will need to be phenotyped and treated with additional therapies according to the presence of volume overload, to the presence of sinus rhythm heart rate greater than 70, presence of coronary artery disease, iron deficiency, where appropriate CRTP or D or ICD. And why that is important? It is important because if we start with the new full guideline-directed medical therapy, we add life to our patients. I mean, you can see that the full therapy reduces by more than 50% all-cause mortality. But what does it mean in reality to our patients? If we take here this patient of 55, if that patient is started on a comprehensive therapy, after 5 years, they would have increased by 9 years their life expectancy. And if they started at an age of 65, they would have gained 9 years of event-free survival. Now, the issue is now how we do sequence and how do we initiate therapy. If we go with the old way of implementing therapy, so starting, say, ACE inhibitors and beta blockers, and then starting all the other medications, that would have taken 28 to 56 weeks for a full implementation. Now, we know from from CBS3 that we can start the ACE inhibitors and the beta blocker together. It is better to start always the ACE inhibitor first and the beta block later. because if we start the beta blocker before an ACE inhibitor, we increase hospitalizations. But we also know that we can start the SGLT2 inhibitors and the MRA at any stage. And we will see that later. Now, when do we need to start? I mean, it's, of course, the guidelines say that we need to start at any encounter with patients with heart failure. And the data from STRONG-HF have further supported this rapid initiation after discharge. The STRONG-HF randomized more than 1,000 patients were hospitalized for acute heart failure, were not on guideline-directed medical therapy, with an high-intensity care with patients seen every 2 weeks and compared to standard of care. You can see that that type of protocol led to a full implementation of beta blockers, ACE inhibitors, MRAs. And however, even with that very strong and very aggressive approach, only 50% of patients got to the maximum dose of guideline-directed beta blockers. So the question is now, is the dose really what is mandated by the studies, or should we individualize the dose? Now, regarding the initiation, we know that the 2023 update of the 2021 guidelines have changed from 1C to 1B, the recommendation for an intensive strategy of initiation and rapid up titration of the therapy. So the first question that was on the title of my talk on when we should start when patients are ready to be discharged, and when they're ready to be discharged, we need to be sure that they are on full medical therapy, at least with an initial dose of those guideline-directed medical therapy. Now, how we can implement it comes later. And this data comes from the Evolution-HF, a study that Gianluigi Savarese carried across the globe, including patients from Japan, Sweden, and America. And as you can see, the implementation of medical therapy is much faster in Japan compared to Sweden, and much, much faster than America. And this is probably related to the fact that in Japan, the hospital stay is longer. So longer hospital stay is associated with a better implementation of medical therapy. But the other important observation from the Evolution-HF was that a significant proportion of patients discontinued. You can see here in red the proportions, the sacubitril valsartan, ACE inhibitors, ARBs, beta blockers, and MRAs. And those who stay on therapy, often they use a low dose of these medications. Now, why is that is the case? Is because we are lazy and doctors do not implement medical therapies? I mean, that can be the case sometimes, but the real reason is that there are some limiting factors in the implementation of medical therapies in our patients. And we know that all medications have, all our medications, all the life-saving medications and the 4 pillars have a significant effect on blood pressure, heart rate, GFR, and potassium that often are the limiting factors in the implementation of medical therapy. Often we fear that, for example, MRAs may have an impact and may reduce blood pressure. This is not really the case in those patients with a low blood pressure. You can see these are data from the MRA studies. They've clearly demonstrated that in those patients with a low blood pressure to start with, the blood pressure actually increased with the MRAs. The only patients where a decrease in blood pressure was observed were hypertensive patients, so those patients with a systolic blood pressure greater than 135 millimeters of mercury. So we can start the MRAs even in those patients with very low blood pressure. Similar data is for the SGLT2 inhibitors. These are data from DAPA-HF. As you can see, those patients with a blood pressure less than 110 millimeters of mercury, you see that they, at the end of the study, they have a reduction in blood pressure of 1 millimeter of mercury. So it is very safe to start in these patients, and even in patients with very low blood pressure, there is a significant effect of the SGLT2 inhibitors on all the endpoints. Now, more difficult is the implementation of beta blockers. These are data from CBCELD, where they've adopted and fast up titration and forced up titration of bisoprolol and carvedilol. But you can see that even with the forced up titration, only 20% of patients were able to take the full dose of bisoprolol or carvedilol. The vast majority took between 25 and 50% of the dose. And this is because there were problems with sinus block, AV block, worsening heart failure, and significant bradycardia. But regarding the beta blockers, there's evidence that what matters is the target heart rate rather than dose, and these are data from a cohort study where they looked at patients who were either randomized to a guideline or heart rate targeted therapy. You can see that it doesn't matter and whether they take 100% of the dose or whether the strategy is to achieve a heart rate less than 70 beats per minute, they're the same prognostic benefit. And a meta-analysis of all studies with beta blockers demonstrated that what is important in the use of beta blockers is the heart rate reduction rather than the beta blocker dose. Now, for this reason and for the management of patients once they are discharged, we've developed this algorithm where basically we suggest to adjust the implementation of medical therapies according to heart rate, blood pressure, present CKD, and atrial fibrillation. You can see that the suggestion is to start all the 4 formulation therapies together. Now, the question is, I'm always asked, should we start them all at the same time? The reality is that when we see patients with heart failure, even with the normal, they are often already on either an ACE inhibitor or a beta blocker or an MRA. So the question is just one or that one or the 2 that are missing from their medications. So once they've started, then the implementation has to be done according to the heart rate or blood pressure. And when we look at the phenotypes that are most frequently associated with a greater mortality and morbidity, we see that those with high heart rate, low blood pressure are those with higher mortality, cardiovascular death, hospitalizations, both in hospital and out of hospital. So how do we approach these patients with low blood pressure? And I mean, if they are on the started on medical therapy, we should use the lowest beta blocker dose and maybe control the heart rate if they are in sinus rhythm with ivapadine or digoxin if they are in atrial fibrillation, and then slowly use the ACE inhibitors, but use the MRAs because, as I showed you, they have no negative impact on their heart rate. So in those with a high heart rate, regardless of the dose of beta, once they are full dose of beta blockers, then we need to use ivapadine and other medications. So in conclusion, the treatment of the heart failure with reduced ejection fraction must include the 4 foundation therapy, and these should be started at any encounter. So the initiation has to be simultaneous, and it's warranted at discharge. They should be started as soon as patients can be weaned out of infusions and can start taking medications during hospitalizations. And then at any encounter, it doesn't matter whether that encounter is in the outpatient clinic, is in the GP clinic, or it is in is with the pharmacist or with the nurse. Then at any encounter, there are according to the patient phenotype. And I'll stop here, and I'll be happy to take your question.
Thank you very much, Dr. Rosano. This is Nabil Farag. And I would like to start by a question for you. As regard the up titration of RNA ACE and MRA and up titration of beta blockers, you mentioned that achieving the heart rate between 60 and 70, whatever the dose of beta blocker is beneficial, but up titration of ACE and ARNI to the maximum dose is the most important. So if the patient is receiving a small dose of beta blocker, achieving a heart rate between 60 and 70, and another patient receiving a higher dose of beta blocker, achieving the same heart rate between 60 and 70, do you think the same benefit of both?
Yes, and that has been clearly shown, and has been clearly shown by several meta-analyses, by the study from Corletto. So, and that is based on most probably what Professor Mehta showed many years ago on the sensitivity of the beta receptors on in the heart that is different in patients with different level of heart failure and difference amongst patients with different heart rates. So the need for beta blockers is related to their sensitivity of their beta receptors, and this is why the clinical trials did not demonstrate any difference between the dose at target with heart rate and dose at target with dose.
Another question?
Thank you, Professor Rosano, for your comprehensive lecture. In every day in our practice, we are facing patients with heart failure and concomitant renal disease. I think there is no definite cutoff point to define the patient with significant kidney disease. Some could assume that you couldn't start, for example, ACE, ARBs, or ARNI, or mineralocorticoid receptor antagonist if the create exceeding 3, and the other school would determine the decision according to percentage of elevation of create when you start, for example, ACE, ARBs. For example, 50%, you can halve the dose, 100%. Which school do you follow, and how could you define significant renal disease? And what is your strategy to be followed? Do you prefer to have the doses, for example, of ARNI, ACE, mineral receptor antagonists, diuretics, or you start to stop one of them completely and continue the other? Which strategy do you follow? Thank you so much.
Yes. First of all, let me clarify a very important point. There is a difference between starting dose and continuation. Now, most of the trials have not set a stopping rule for the ACE inhibitors and the MRAs. So that means that patients with an eGFR greater than 2025 they should be started. But then if the eGFR declines, there's no reason to stop, because the trials didn't show any, they didn't have any stopping rule, except for rails, but not for the emphasis, for example. And therefore, I would go with the SBCN with the indication of the different drugs. So ACE inhibitors not below 3rd, and MRAs not below an eGFR of 30, ARNI not below an eGFR of 25, and then continue, because even if you continue those medications, then you have a survival benefit. At the end, those patients are going to die because of heart failure, not because of kidney disease. And therefore, if you discontinue an ACE inhibitor or an MRA because their eGFR falls, then those patients will be increased risk of mortality and they will die because of heart failure. So we have to get rid of the old concept that we need to protect the kidney. In patients with heart failure, heart failure is the priority. So the starting group is based on the baseline eGFR, but then if the eGFR falls, then we should continue. There are data from DAPA-CKD that even patients who are in waitlisted for renal replacement therapy, the continuation of the SGLT2 inhibitors was beneficial in delaying the time to renal replacement therapy. That tells you that the cardiovascular medications are always important. And if you discontinue, there will be a worsening of the neurohormonal status, and therefore there will immediately worsen, and their renal function often will even worsen even more.
Thank you so much, Dr. Rosano. And for the sake of time, we have to move to the second speaker. It's my pleasure to introduce Professor Peter. Professor Peter is a professor at University of Belgrade, Faculty of Medicine and Heart Failure Center. He is the current president of the Heart Failure Society in Serbia, and he is a past president of Heart Failure Association, European Society of Cardiology.
Do they have my slides? It is my great pleasure once again to be here. I would like to thank you very much, the president of the Egyptian Society of Cardiology, and also the president of the Congress, to having me here. What is extremely important is to understand that European cardiology is changing. What that really means, that means that the strong, vital society are taking over, and I may say that Egyptian Society of Cardiology is one of them, having in mind the Euro program, which just started, and everything you do, it seems to me that European Society of Cardiology should count on Egyptian Society of Cardiology to the higher extent. Guideline-directed medical treatment in heart failure is something which is now an excellent and very important topic for all of us. There are many comorbidities which these patients are exerting, but also there are many cardiovascular disorders which are ending with CKD, including ischemic heart disease, left ventricular systolic dysfunction, valvular heart disease, cardiac arrhythmias, and cerebral disease, ischemic and hemorrhagic stroke. All these diseases may be the trigger of showing the chronic renal disease and everything which comes to the CKD stages 3A and also GD5. It is important to understand that the holistic approach to the body is when one organ fails, another organ may be showing the dysfunction as well. There is a clear-cut bidirectional relationship between heart failure and renal dysfunction, and we know that in patients with heart failure, we can have glomerular hyperfiltration and accelerated nephron loss, then we have increased fraction filtration per repron. But also, what is the most important is increase NA reabsorption in distal tubule and activation of the tubuloglomerular feedback. All these are coming to the decrease of filtration fraction, giving rise to the different pathophysiological mechanisms which are practically involved in the development of heart failure. One of the most important is venous congestion on glomerular filtration pressure, which is a mechanicistic negative effect on the glomerular filtration pressure, and negative pressure which is developing into the Bowman's capsule. So this venous congestion is something which we sometimes forget, but it's extremely important. And also it goes with the clinical fact that with most congested patients had also the highest decline of the renal function. Obviously, CKD in chronic heart failure can be found significantly higher in approximately half of heart failure patients. However, 10% of heart failure patients who had advanced heart failure has clear-cut renal dysfunction, non-depending of the heart failure phenotype. So both HFpEF and HFrEF may be associated with the decrease in renal function. Clear cut in many observational studies, but also the studies regarding the use of different drugs, the presence of the CKD was found to be the independent risk factors, and those patients have almost 2 times higher mortality or heart failure hospitalization comparing with those who has the normal renal function. One of the most frightening phenomena in heart failure is a worsening renal function in patients with heart failure. And this occurs in approximately 25% of our patients, and it's also associated with the increase in mortality and risk hospitalization, going from 1.3 to 1.8-fold high risk in patients with the worsening of heart failure. Even more, the worsening of heart failure can be the first step in developing the worsening of the heart failure. And therefore, these two phenomena are clearly connected. If we look at our attempt to stop or improve CKD in patients with heart failure, we can clearly see that this milieu, this landscape is extremely complex. We try to block different pathways, and as you can see, some new drugs are on the game, but also some old drugs like ACE inhibitors, beta blockers, and then ARBs as well are some who are extremely important. Different drugs are affecting the patient with various degrees of CKD in a different way. What we tend to do is to use the optimal medical treatment in those patients, trying not to affect the renal function, try to improve or keep steady the renal function. Beta blockers, ACE inhibitors, and MRI are also working in the same direction, giving us the possibility not only to reduce heart failure hospitalization, but also to lessen the symptoms and improve mortality. Let's look at the landmark clinical trials in HFrEF. And what we can say is that we can find between 20 and 60% of mild to moderate CKD. And this is extremely important because in those trials, the patients with advanced CKD were not involved. Therefore, cardiovascular death and heart failure hospitalization were very much reduced by the use of ARBs, beta blockers, and MRIs. However, what is essential is to assess the renal function at the beginning of the treatment. This complex graph is showing that all-cause mortality, cardiovascular death, and heart failure hospitalization may be very much improved if we assess the renal function at the beginning of the treatment, like absent, moderate, and strong, and then divide our treatment in 5 stages, giving rise to the stage 5 as the most important one and is the most complex. Obviously, some drugs which we are now consider older are excellent, and these are ACE inhibitors and ARBs. They are protecting kidneys and can decrease the slope of eGFR decline, leading to the positive clinical outcome. The same is true for sacubitril valsartan, and as it was already pointed out in the several studies, but also in the guidelines, having in mind the results of Paradigm and Paragon, the patients are showing less decline in eGFR under the effect of sacubitril valsartan. A slow rate of decrease of GFR is also seen regarding the comparison with comparator, but also with the ACE inhibitors. And complex pathophysiological mechanisms within the nephron are very much involved and are very much today known how the sacubitril valsartan acts in those group of patients. It is probably one of the explanations of the excellent effect of ARNI in patients with HFrEF. The breakthrough are obviously SGLT inhibitors, which are protecting kidney function to the higher extent. The results from DAPA-HF and the liver, which I'm showing here, are very indicative because they are showing the decrease of the renal function at the beginning and then further on the improvement and steady course of the development of the renal function. The question, what is the lower eGFR we should use, is probably 20 milliliters, because everything which is less than that may be associated with a high risk. In addition to that, across to different spectrum of eGFR, we may clearly see that in patients with HFrEF and HFpEF, SGLT2 inhibitors are associated with great risk reduction in cardiovascular mortality and heart failure hospitalization, independent, and this is extremely important, of baseline eGFR value. Let me remind you that in DAPA-HF, we have around 40% patients with CKD, eGFR more than 30, and in EMPEROR reduced 53%. So this is showing how important is the novel treatment regarding the comorbidities, and CKD is one of the most important. What do the guidelines say? Absolutely use the recommendation of the optimal medical treatment in mild to moderate CKD in order to improve clinical outcomes. However, the things are more complicated when it comes to the patient with advanced CKD, and the guidelines are saying that there is little evidence to support optimal medical treatment in those patients. So why CKD is so important? Because this is one of the most important factor in underutilization of the heart failure, and I'm showing you the national studies from Spain, United States, and Sweden, in whom CKD was associated with a lower likelihood of GDMT prescription. What were the reasons for underutilization? They are very well known, but not easy to handle in everyday practice. It is obviously the risk of adverse effect and tolerance. Then elderly population, it's a big problem. And then more severe heart failure is associated with more underutilization of optimal medical treatment in patients with a CKD. And then at the end, we should count that all these patients may be frail and have a greater burden of comorbidities. We developed an excellent way how to improve optimal medical treatment in patients with CKD. But these are all very well known and are very well clinically defined. Starting low doses, using sacubitril valsartan instead of ACE inhibitors. If needed, we can use potassium binding drugs. Then frequent monitoring of this patient, electrolytes and eGFR. We obviously need to avoid nephrotoxic agents. Iron deficiency, anemia, and vitamin deficiency are also very important. At the end, ladies and gentlemen, dear friends, I may say that we developed an excellent integrated approach to cardiorenal risk, and the reduction of cardiorenal risk is going from the risk factor management to the use of different drugs which were proven to be beneficial: ACE inhibitors, SGLT2 inhibitors, and finerenone. For this, I would like to thank you very much for your attention and tell you that the problem of comorbidities in heart failure is one of the major ones. We know today that we are working on this, but that is probably a way to further improve the survival of our heart failure patients. Thank you very much for your attention.
Thank you so much, Professor Severovich, for this wonderful presentation. I think it's a common problem for physicians treating heart failure patients the concern about kidney function, low blood pressure, hyperkalemia. So when initiating guideline-directed medical therapy, we need for our young fellows to know the tips and tricks when starting these medications in patients have a baseline serum creatinine high, GFR within 30 or less than 30. So what's your recommendation for?
I pointed out that the strategies to improve optimal medical treatment in patients with CKD is very well known. And as you pointed out, we need to let know all our younger physicians that in most cases, our optimal medical treatment, according to the phenotyping, which was already mentioned, needs to be applied. As I said, less than 20 milliliters eGFR is something which is probably the border, not to go too invasive with different drugs. However, it should be said that we know today that there are some drugs which have very beneficial effect on the patient with CKD and which have no hemodynamic effect, and they are beneficial in many ways, and these are SGLT2 inhibitors. So in the sense of having phenotyping the patient, SGLT2 inhibitors should be always the first one. And then phenotyping the patient according to the pathophysiology of its heart failure, but also according to the long-term outlook of the survival of those patients.
Great. Any questions?
Any question? Okay. Thank you very much for this great presentation, and it's our pleasure to have you here in this conference, an honor to have you here. Thank you very much. We go to the third speaker, Professor Haitham. Professor Haitham is a professor of cardiology at Shams University, and he's going to present one of the important topics, guideline-directed medical therapy in patients with improved ejection fraction, and heart failure with improved ejection fraction is one of the terms recently introduced in the guidelines. Before we have heart failure with reduced ejection fraction, mildly reduced and preserved, and now we have heart failure with improved ejection fraction.
Thank you, Professor Nabil, Professor Magdi, Professor Hossein. It's my pleasure to be here, of course. And it's my pleasure to start the Egyptian part of the conference. Actually, the guideline-directed medical therapy to improve the ejection fraction. I think you know it. You know that we have to give ACE inhibitors or ARNI, we have to give beta blockers, we have to give MRA. And this is because the guideline-directed medical therapy for the patients with heart failure with reduced ejection fraction is well known since the late 80s. We have to give ACE inhibitors to improve the reverse remodeling as well as the ARNI, and this is supported by a lot of trials. Beta blockers to decrease the arrhythmic mortality, decrease the workload of the heart, and also improve the mortality. The MRAs are the same, and recently the sodium glucose cotransporter 2 inhibitors. But this is very true with the patients with heart failure with reduced ejection fraction below 40%. But up to this point, there is no dedicated trial for the patients with heart failure with improved ejection fraction because the definition was not very clear until very recent. And actually, the only trial that shows that we have patients that improved by these drugs, in the patients, I mean, with the heart failure with improved ejection fraction, is the DELIVER trial for the dapagliflozin and the sub-study from the PARADIGM trial for the ARNI. So we know all the therapy we use for the heart failure with reduced ejection fraction can work in our patients. But why heart failure with improved ejection fraction is a little bit different? Because your patient will ask you some questions. Am I recovered now? Is it equivalent to the recovery of heart failure? The patient is recovered when the ejection fraction is improved? Do I have better prognosis than the patient with reduced ejection fraction or not? Can I stop my medication now? Can I remove any implantable device like an ICD or CRT if I improve the ejection fraction? And what to do next in our patients? So we have to answer these questions in order to know the heart failure with improved ejection fraction. Actually, the definition is a little bit difficult because We have different definitions according to the studies, starting from the Valheft trial. It said that if the ejection fraction improved by 5%, this is an improved ejection fraction. And we have different studies that said that if the ejection fraction improved from one stage, like the heart failure with the reduced ejection fraction, to the mid-range or preserved, this is an improved ejection fraction. But this is not the universal definition. The universal definition, we agreed now that if you have an entry point of ejection fraction less than 40%, and then you have a 10% improvement in the ejection fraction, and the second measurement is above 40, this is a heart failure with improved ejection fraction. But do you think using the ejection fraction as a marker or a surrogate for the reverse remodeling and improvement is very efficient? Actually, it's very easy to measure the ejection fraction, but we have many caveats, including it does not exclude heart failure. As you know, by definition, heart failure is a clinical syndrome. So the patient might have a very good ejection fraction, but still he's in heart failure symptoms with elevated biomarkers like the BNP. And also the ejection fraction is affected by the observer variability, inter-observer and intra-observer variability as well. Other markers might be more related to the reverse remodeling, including the LV volumes, which you measure in the, like after implanting the CRT in our patients. The global longitudinal strain is a better way to reflect the outcomes than the ejection fraction. And actually, in some patients with heart failure with preserved ejection fraction, we can find that they have abnormal global longitudinal strain in comparison to the normal ejection fraction. But the ejection fraction is a simple way, and the improvement or fluctuation of the ejection fraction can give us an idea about the improvement of these patients regarding the prognosis. But what's the prevalence of improvement of the ejection fraction? Actually, it's also very variable in the studies according to the definition. But in summary, it's something between 10 to 40% according to the definition. And of course, if you have some reversible factor like ischemic heart disease to be corrected, or some left bundle for which you can implant a CRT or something like this, or correction of anemia, correction of arrhythmia like the tachy-induced cardiomyopathy, all of these will improve the ejection fraction and increase the prevalence of the heart failure with improved ejection fraction in our patients. And regarding the prognosis, we have a meta-analysis including something like 9,500 patients of about 9 studies that shows that the prevalence is something between 22 and 23%. So a quarter of the patient will have a heart failure with improved ejection fraction, and this was reflected by a significant reduction in all-cause mortality and hospitalization, the composite event, the cardiovascular mortality, and all-cause hospitalization in comparison to the heart failure with preserved and with reduced ejection fraction as well. And regarding the therapy, as I mentioned, all of us know that we have to put the 4 pillars for our patient. We have to put ACE inhibitors or RAS inhibition by ACE inhibitor, ARNI or ARB. We have to put a beta blocker for our patient, mineralocorticoid antagonist, and then we'll add sodium glucose cotransporter 2 inhibitors, of course, and some diuretics if the patient started with the diuretic and do not stop the medical therapy even after improvement of the ejection fraction, as I will show later for our patients. And this is, I think we have a missing slide. But actually, the 10 heart failure trial, although it was on a little number of patients, 51 patients, and the follow-up was only for 6 months, it shows that if you withdraw the medical therapy, you will get a relapse in about 44% of your patients. And the relapse is gradual. So after 1 month, you will get an increase in the heart rate by about 7 beats per minute. After 2 months, slight increase in systolic and diastolic blood pressure. After 4 months, you will have a drop in the ejection fraction by 4%, increase for end diastolic volume index, and increase for LV mass index. So you will get an adverse remodeling once more. And after 6 months, the global longitudinal strain will decrease with increase in the LV cell mass index and the LV matrix mass by about 1.7 grams. So you will get an adverse remodeling once more and the relapse of the heart failure. So this is the TREAD heart failure, as I mentioned. And this is the therapy withdrawal. And what's next? What we have to do with the patients with improved ejection fraction? Actually, your patient should be followed up on a regular basis on the clinical management, clinical evaluation every 6 to 12 months with natriuretic peptide measurements every 6 to 12 months to ensure that he is still in the remission. Imaging by echocardiography, and sometimes you should consider cardiac MRI for your patients in order to that he have a better prognosis for the recovery of the heart failure without presence of any fibrosis inside. The pharmacotherapy should be continued indefinitely in our patients with consideration of sodium glucose cotransporter 2 inhibitor initiation if he is not initiated yet. Device therapy, you should continue the CRT if the patient baseline is left bundle branch block, and the ICD, I will give you a little hint about the ICD later on. Genetic testing is very important because some genes like the Titin gene abnormality is associated with better prognosis and improvement of the ejection fraction, but other genes like the lamine is not associated with this improvement, and the patient is not expected to improve regarding the ejection fraction. So what's next? Our aim is to keep the patient in a remission, in an improved ejection fraction, and the aim, of course, for the recovery. But sometimes if you neglect the therapy or the patient has some comorbidities like non-adherence to the therapy, the arrhythmias, hemodynamic affections, the anemia, and this will go once more to the heart failure with reduced ejection fraction. So you should avoid the extrinsic and intrinsic predictors of reducing the function once more. So in summary, the management of the heart failure with improved ejection fraction, this is the definition. You should treat any reversible cause, including the ischemic etiology. The patients with tachycardiomyopathy, you should treat the tachyarrhythmia like atrial fibrillation. The valvular heart disease, you should treat the valvular heart disease. If in the patient is hyperthyroid, you should treat the thyroid. Stress-induced cardiomyopathy is usually irreversible after removing of the stress. And then you should continue in the medical therapy indefinitely, including the 4 pillars, and continuation of a small dose of oral diuretics as recommended if the patient has some slight congestion. Regarding the device therapy, this is very important because some patients, when you have an improved ejection fraction, they ask about removal of the device like the CRT or the ICD. If the patient is a left bundle, the only evident therapy to treat electrical dysynchrony with the left bundle is the CRT up to this point, and recently you have the conductive system pacing as well. And we have a trial, it's called the STOP CRT trial, in which the patients who are super responders to the CRT, some of these patients already, they stopped the treatment and there were no relapse in these patients, denoting that the main underlying mechanism of heart failure in these patients was the left bundle branch block. So the CRT should be kept inside this patient indefinitely. Regarding the ICD therapy, actually if the ICD for secondary prevention, of course you should not remove. For the primary prevention ICD, you know that the implantation is a little bit debatable, and the guideline medical therapy will take some time to act or to reverse remodel the left ventricle. So the guidelines recommend at least 3 months of medical therapy before taking the decision to implant an ICD in dialytic cardiomyopathy because it might improve the ejection fraction, and then the ICD will not be indicated once more. But sometimes, if the patient is promising or have some improvement in the ejection fraction, you can wait up to 9 months in this type of patients before implanting an ICD. But the improvement of the ejection fraction, even if it is above 45, it does not eliminate the arrhythmic death completely. You have something like 3.3% of annual sudden cardiac death in these patients, even if the ejection fraction is above 45%. But why we don't like to implant an ICD in this patient? Because most of these patients are young and they will have supraventricular arrhythmias, or they will have inappropriate shocks. They might have an infection in the device. So we try to avoid the ICD if possible. And we have a trial, it's the SAVE ICD trial. In this trial, prolongation of the duration of the medical therapy up to 9 months, we avoided something like 25% of implantation of ICD therapy in these patients. So for the battery replacement, as I mentioned, the arrhythmic death is not eliminated by elevating the ejection fraction even below, above 45%, and you still have something like 3.3 instance of arrhythmic death in these patients, especially if the patient is young, like the Danish trial mentioned before. So the consensus is to replace the generator for the patients, even with the heart failure with improved ejection fraction. The presence of high-risk genetic variants and the extent of myocardial fibrosis in the cardiac MRI with the cardiac biomarkers like the natriuretic peptide, and this might identify patients who will still benefit from the ICD and will not experience much improvement in the ejection fraction regarding this part. So my take-home message that the heart failure with improved ejection fraction is very heterogeneous, so there is no universal definition of the state of the improvement exists. The most widespread criteria include ejection fraction less than 40% and with increase of 10%, and you have the second measurement above 40%. One should rather use the term transient remission of systolic dysfunction rather than LV recovery, because he might go into relapse once more. Withdrawal of the guideline-directed medical therapy is associated with worse outcome, and the device therapy should be kept for your patient. Thank you very much.
Thank you very much, an extraordinary talk about very hard topic. I have one comment and one question. The comment goes that at the time we did the universal definition of myocardial heart failure, heart failure with improved ejection fraction was not very much on the table. So that's why there is no universal definition of this type of heart failure. And it should be done, and I may tell you that there is a plan next year to do another revision of the universal definition of heart failure, and probably we're going to get it at the time. And another one is we have the reports from France, Hospital La Rabosière, that arrhythmic event may be worsening, more frequent, may be worsening during the getting let's say, ejection fraction to the normal, which means that the ejection fraction is improving, but arrhythmic event could become worse. Could you give us any clues or any comments on the topic?
I mean, I think this is known from even the very early studies of heart failure. When you find the patients with a little bit better ejection fraction, he will die most probably from arrhythmic death rather than heart failure death. So probably I think during the process of reverse remodeling, you have some abnormality in the conductive system or abnormality related to the scar tissue or the entry mechanism inside this ventricle, leading to more ventricular arrhythmias and more sudden death in these patients.
Thank you, Professor Haitham, for elegant lecture and important topics. It is very important to insist. It is malpractice to stop treatment after improving myocardial function or after going to for heart failure with improved function. Because I have faced patients, even abroad, go to outside and stop treatment by doctors and relapse occur. It's very important. My question, why don't stop diuretics? Diuretics not affect prognosis, not affect mortality or morbidity, and patient is dry, and now it is improved function. I can stop diuretics.
Yeah, this is a very good point, and this was my practice as well. But I mean, when I revised this topic, and there was some trials when the patients when the patients were on high dose diuretics, especially in hospital, and then he got some improvement of the ejection fraction. Keeping even a small dose diuretic in the therapy will prevent the remission much better. So even it shouldn't be every day, but every other day or something like this, in order to keep the patients in a dry form, I mean, and improving the symptoms, of course.
Okay, another question. Some patients have viral myocarditis, the self-limiting disease. So after improving the condition, patient recover to normal. Continue treatment, or I consider this it is just viral carditis?
I mean, in the 10 heart failure trial and in all of the trials regarding the follow-up of the guideline directed therapy, they didn't differentiate between the phenotypes of heart failure, because some of them were peripartum cardiomyopathy, and some of them were something like stress-induced cardiomyopathy and tachy-induced cardiomyopathy. And most of these, we can find some recovery in this heart failure, but still they continue on the guideline directed therapy without stopping it.
But we need to be very cautious about the word of complete recovery, because we have to do a CMR imaging tool to see what's going on at the level of serious structures, myocardial fibrosis, because this is very important before considering to stop the medications. In patients who are apparently normal, ejection fraction apparently normal, CMR is important.
I have case of, we have research about myocarditis, and some patient after CMR, everything get normal. Continue treatment or not? This is my question.
My impression is to continue treatment for this patient, because he is very susceptible to have another attack, even after another viral infection or something like this. At least the 4 pillars.
Yeah, regarding one important subject that we always ignore is the atrial fibrillation, fast track sinus rhythm maintenance, I witnessed myself about a very big series of heart failure with AFib that ended up all the ejection fractions of all patients improved even to normal, except maybe the hypertrophic cardiomyopathy and some myocarditis, ex-myocarditis with AFib. But AFib, maintenance sinus rhythm, even the heart rate target that is a myth, 110 is incorrect. We have to maintain them in sinus rhythm or ablate AV node if it's chronic.
This is perfect. So this is after the
really
Castle HF
important.
trial. It's the first line therapy now to maintain sinus rhythm by ablation. This is very important, especially in the patient with heart failure, of course.
And this is in the Castle trial, they included the ischemic cardiomyopathies, but when you go more selective and more you have even improvement more than 95% in these patients if you succeed in maintaining them in size.
I agree completely.
Or ablating AV nodes.
Thank you very much.
Okay, thank you so much,
Haitham, for,
Professor Haitham. And now we will shift to
Thank you.
the next speaker, Professor Mahmoud
very much.
Hassanin, Professor of Cardiology, Alexandria University, who will give us an account about iron deficiency in heart failure treatment in acute and chronic heart failure. تفضل يا فندم.
First, I would like to thank the presidents of this meeting for their kind invitation. Really, it's painful. It's an honor to participate in this meeting with the Egyptian Society of Cardiology. My talk today is about iron deficiency in heart failure. First, a question to the audience: who prescribes intravenous iron for heart failure patients before hospital discharge? Please raise your hands. It's a minority, okay? It's a minority. Okay. So iron deficiency is common in patients with heart failure. And this is from an international cohort of patients with heart failure. 50% of all patients with heart failure have iron deficiency. And what is more interesting, that iron deficiency is common regardless of the presence of anemia. As we see in this graph, about 46% of patients had pure iron deficiency without anemia. What is the impact of iron deficiency on patients' outcome? There's worse survival of patients with iron deficiency compared with those without iron deficiency. And even the scenario is much worse when the patient has both anemia and iron deficiency. Iron deficiency is also common in patients with acute heart failure. As we see, males, about 69% of males hospitalized with heart failure have iron deficiency, and the prevalence is even more in women hospitalized with heart failure. 76% of 75% of females hospitalized with heart failure have iron deficiency. So what are the potential causes of iron deficiency in heart failure? There are multiple causes: malnutrition, malabsorption, and gastrointestinal blood loss, which will lead to reduced iron storage and absolute iron deficiency, and inflammation, which is always present in patients with heart failure, which leads to reduced iron mobilization, leading to functional iron deficiency. So we have two biomarkers of iron storage and utilization: serum ferritin for iron stored, and transferrin saturation, which is the ratio of iron to total iron bind capacity, which is a marker of iron utilized. So there are two dual effects of iron deficiency. First, defective oxygen delivery due to anemia, leading to diminished oxygen delivery, and defective oxygen metabolism, leading to myocardial dysfunction and decreased oxygen utilization. This is one of the first trials of iron therapy in patients with heart failure, the FAIR heart failure trial. The chief investigator was Professor Anker. And as you see here, patients with heart failure with reduced ejection fraction were given ferric carboxymaltose. And at week 24, 50% of patients on iron therapy versus 28% on placebo. They reported they were much or moderately improved. And the New York Heart Association function class was improved in 47% of patients on iron therapy versus 30% on placebo. Again, second endpoints, the 6-minute walk test and the quality of life was improved using the EQ 5D and the KCCQ. Another trial, the confirmed heart failure trial, the leader, the chief investigator was Piotr Ponikovsky, and patients with heart failure with reduced ejection fraction were randomized to ferric carboxymaltose versus placebo, and as we see, the primary endpoint was marked improvement in the 6-minute walk test, and fatigue score was much less in patients on ferric carboxymaltose. The most recent trial, the HeartFeed trial, which was presented in European Congress of Cardiology last August 2023, it included a large number, the largest number of patients, more than 3,000 patients, who were patients with heart failure with reduced ejection fraction, randomized to ferric carboxymaltose versus placebo. And as we see, the primary hierarchical endpoint, all-cause mortality, was improved in patients on ferric carboxymaltose, and so was the total heart failure hospitalizations and the 6-minute walk distance. However, time to cardiovascular death did not differ between the placebo arm and the treatment arm. This is a meta-analysis published in 2023, a very recent meta-analysis, which included 10 randomized controlled trials involving more than 3,000 patients with heart failure and iron deficiency. And the primary endpoint, heart failure, hospitalization, and cardiovascular mortality was reduced by 25% versus standard care or placebo. Another recent meta-trial in 2023, again including more than 4,000 patients with heart failure with reduced ejection fraction. Half of the patients were randomized to ferric carboxymaltose and the other half to placebo. And the key findings were the intravenous ferric carboxymaltose was associated with a significantly reduced risk of the composite of cardiovascular death and total cardiovascular hospitalizations. So what do the guidelines tell us? In 2021, the Class 1C recommendation was to periodically screen all heart failure patients for anemia and iron deficiency with full blood count, serum ferritin, and transferrin saturation. And ferric carboxymaltose should be considered for iron deficiency to alleviate heart failure symptoms, improve exercise capacity, and quality of life. And please take care that oral iron is not recommended for the treatment of iron deficiency. It does not work, okay? It's intravenous iron which benefits the patients with heart failure. And again, treatment of anemia in heart failure with erythropoietin stimulating agents is not recommended in the absence of other indications for this therapy. It's class 3 recommendation. It's prohibited. And in the focused update 2023 of the heart failure guidelines, the recommendation was promoted to class 1 level of evidence A. Intravenous iron supplementation is recommended in symptomatic patients with heart failure with reduced ejection fraction and heart failure with mildly reduced ejection fraction and iron deficiencies to alleviate heart failure symptoms and improve quality of life. It's class 1A, just like the 4 pillars of heart failure treatment. And intravenous iron supplementation, either with ferric carboxymaltose or ferric derismomaltose, should be considered in symptomatic patients with HFrEF and HFmERF and iron deficiency to reduce the risk of heart failure hospitalization. So the ESC definition of iron deficiency is either serum ferritin lower than 100 or serum ferritin between 100 and 299 and transferrin saturation less than 20. And we calculate the iron dose using the Ganzoni formula. This is a patient with heart failure near class 3, Serum ferritin was 10 microgram per liter, transfer saturation was 11%, hemoglobin was 11.2 grams per deciliter. So iron dose was calculated as 1,000 milligram of ferric carboxymaltose, which was given to the patient before hospital discharge. And this is a calculator. One of our young colleagues was in France, and he showed me this calculator during our clinical round, that every fellow in this big hospital had this calculator in his pocket, and just before a hospital discharge of heart failure patients, he calculates the appropriate dose of iron, intravenous iron, and the patient is given this dose before hospital discharge. And what the FDA said, that a drug that improves symptoms or function when added to standard of care would be valuable even if it did not improve survival or hospitalization. And this applies to heart failure patients. Even though iron therapy did not improve total mortality or cardiovascular mortality, but it does improve the quality of life of patients, and this is of utmost importance. So in conclusion, iron has an essential role in oxygen transport, and iron deficiency can be harmful even in the absence of anemia. Iron deficiency remains under-recognized, however, it can be easily diagnosed and managed. Iron deficiency is frequent comorbid condition in patients with heart failure and associated with a poor quality of life, exercise capacity, and the higher risk of hospitalization and mortality. Correction of iron deficiency improves exercise capacity, quality of life, cardiovascular and mortality outcomes, and periodic assessment of iron deficiency and anemia in all patients with heart failure as part of clinical evaluation 1 or 2 times per year, depending on the severity of iron deficiency and heart failure, and intravenous iron administered as needed. Thank you for your attention.
Thank you, Professor Mahmoud, for elegant lecture. One small question because we have short of time. Okay, we can.
Thank you very much, Dr. Mahmoud. But I would like to say something, that Professor Dr. Mahmoud Hassanin is one of the pioneers in heart failure in Egypt. And he was one of the leaders in investigating heart failure and sharing registry with the European Society of Cardiology. And it's our pleasure and honor to have you here, Dr. Mahmoud. Thank you very much.
Professor Nabil Farag was co-investigator with me in this region, Professor Magda Abdelhamid and the other, Dr. Amr Bardo, and so many professors in many universities all over Egypt were participating in this registry, which was a part of the heart failure long-term registry of the European Society of Cardiology.
I would like to add, Dr. Nabil, Dr. Mahmoud is one of the founders of the working group of heart failure in Egypt with Professor Wagdi Ayad.
And also let me say that he was the first member of the Heart Failure National Societies 13 years ago. He came and started everything which was in Egypt.
We came to Serbia.
Yeah, of course. The first summit was in Serbia, but later on you developed heart failure with all your friends, colleagues, and professors to the higher extent. And I use this opportunity to thank you very much and congratulate you.
Thank you.
Thank you very much, Dr. Mahmoud. And I think we come to the end of this session to start the second session.
Second session, yes.